Friends, today my topic is Nata 6. Reason of this topic will be clear shortly. A young man presented with large epithelial defect and infiltrate. He had history of some soil fall a month ago. Scrapings revealed fungal hyphae. His records show that about a month ago when it started, it was a small ulcer. Antibiotics were started. After 2 days, prescription was revised and natamycin added in 4 times a day dose. When there was no relief in 3 days, he took another consultation. Here again fungal ulcer was suspected and natamycin prescribed in 6 times a day dose. When he came to us, this dose was being used. I started treatment with standard dose of 1 hourly. In view of large ulcer, oral antifungal itraconazole was added. He responded beautifully. Dose tapering done, and after 1 month dose was 6 times a day. In this case, I was surprised by the cornea's ability to bounce back towards clarity. He was 624 after 2 years. He had responded so well to same drug with which his lesion has increased drastically in last 1 month. So where was the fault? Fault lies in suboptimal dose of natamycin. When we do phaco, we have parameter setting for nucleus removal, which takes care of bulk, and epinucleus is taken care by lowering the settings. We can never remove nucleus with epinucleus settings unless we have a soft nucleus. Same way, we can be occasionally lucky to have a small load of fungus which responds to low dose, but otherwise we need a proper high dose of natamycin initially. This is the protocol being followed at AIIMS. Most of the lesion is taken care by a higher frequency, which is gradually tapered. When 80 to 90% of the lesion has healed, then we shift to 6 times a day dose. Choice of antifungal has been derived from sensitivity profile. Candida is a common systemic infection, but in eyes it happens in less than 1% of the cases. Hence, fluconazole is not a drug of choice. Usually, natamycin remains first drug of choice as it does not require formulation and refrigeration like voriconazole. Vori is the second drug of choice, which is usually added when we find that there is no relief with the nata. And those ulcers which don't respond to both are given a trial with amphotericin. This is LVP protocol. Different institutes have different protocols, and many times they are suited for admitted patients where nighttime application is advised initially. Whether we choose nata or vori, drug protocol remains same, where the drug is started in 1 hourly dose. I am sharing what I usually follow in my practice. I always start with 1 hourly dose. As the intensity and size decreases, tapering is started. I start reducing the drug when 50% lesion appears healed. Natamycin is reduced to 6 times when 90% lesion has healed, and this dose is continued at least 1 week after complete resolution. Oral drugs are given in case of large ulcer, limbal spread or perforation. All these drugs need LFT monitoring. So whenever an ulcer patient comes, we confirm fungal diagnosis on QH, note down the size and depth, and particularly the margins which show the maximum activity. Treatment is started with full dose. When infiltrate responds, margins get organized, infiltrate density and epithelial defect decreases, and drug dose is tapered. Here 50% infiltrate has resolved, so dose is reduced to 12 times a day. With further reduction, dose is reduced. In this journey of 9 weeks, we reach the stage of Nata 6 after 6 weeks. Even in small ulcers, my protocol remains same, and it helps in early resolution. In fact, sometimes it's equivalent to bacterial ulcers. I hope now onwards Nata 6 will never be your starting dose. Thanks for your valuable time.